So let's move on and talk a little bit about kind of stages of infection, Paul, and you can actually talk about diagnosis here, and,
sure.
and also maybe remind people that new diagnosis doesn't necessarily mean a recent infection.
Correct,
right? So.
correct. But since we're talking about stages, why not start at the beginning and realize that people who get infected with HIV can have a clinical syndrome that we call acute HIV infection, which is a lot like infectious mononucleosis. Right. And it's about, the estimates, it's hard to know, but about half the people who acquire HIV are symptomatic. And then the severity of that illness is really incredibly variable, everything from a very mild mono-like illness to, I've seen someone with very fulminant meningoencephalitis very recently who got admitted to our neuro ICU with very, very severe encephalitis from acute HIV. Interestingly, it was an individual over the age of 50 who was from sub-Saharan Africa. And it was really, really interesting. But anyway, the diagnosis during those symptomatic periods early on is actually the HIV viral load test. In most contexts, though, that's not the test we're going to be sending when we want to screen for HIV. We're going to be sending this fourth-generation antigen-antibody combination assay, and that has really improved our ability to diagnose HIV after recent acquisition. It's not quite as sensitive as the viral load test, but it's almost as good. So that's our screening test.
And its price is more expandable.
Yeah.
And its turnaround time is also easier
very
to
fast.
do because it's an ELISA as opposed to a PCR test, so that it can be done more quickly as well.
Right, so that's generally, if you're going to screen someone for HIV who doesn't have acute HIV infection, someone who, has maybe had risk behaviors a couple of years before, who's never been tested before, asymptomatic, it's that fourth generation antigen antibody test that you're going to be sending.
But it is important, Paul, as you said, it's a great test for routine screening. If you encounter someone where you have a high index of suspicion and the fourth generation is negative, they really do need to have an RNA test done.
Yeah, definitely.
It's amazing that the quantitative HIV RNA test, the viral load test that we use for all of our patients, nobody's ever gone to the trouble to get it FDA approved for diagnosis.
Interesting.
Which is annoying, but it's just not, you can't use it for diagnosis. One thing that I just would also mention, just as clinically, because it's important, is if that antigen antibody test comes back positive, it doesn't have enough specificity for you to sort of say that's conclusively the diagnosis, so it has to be confirmed with the second test, which is now called differentiation assay. And in our hospital, where we have a large obstetric service and a lot of women who are pretty low risk are getting screened, it's actually just as common for their screening test, once positive, to be not confirmed as it is for it to be confirmed. So there is a false positive rate in that screening assay.
And so other stages so that's that kind of acute infection. In LA, how are people presenting now?
Yeah, so I mean, obviously we occasionally see people with acute infection, but the majority of people are coming in for routine screening, or increasingly because of guidelines like the CDC guidelines, people are, even without obvious risk factors, are just getting a test. So a lot of people admitted to the hospital, people going to certainly STD clinics and urgent cares are getting screened and getting diagnosed. And I think anecdotally, and I think there's data in other centers, that we are catching people earlier. Because our threshold to screen is now, if you're a warm body, and we think of it, we should do it.
Yeah, sure.
And I think the other thing that Paul just mentioned, taking away the obstacles of getting tested made a huge difference. Taking out the consent form, taking out the counseling before and after has really, really helped. And then also the other thing we've noticed in DC is that if you take the test out of the testing center and put it into the community, people will come and get tested. In fact, for many years they tested people at the DMV in DC because the incidence was so high. And after you got your driver's license, you got a chance to go get tested as well. They stopped doing it because the pickup rate was so small, but it really normalized HIV testing.
And what about advanced disease? Do you guys see that? People presenting with advanced disease still?
We see fewer cases in Philadelphia, people coming in with AIDS-defining clinical events. And in the outpatient setting, we see fewer people with CD4 counts less than 200 at presentation than we have. But occasionally, those people still surface.
We still see a lot of people who slip through the cracks and get diagnosed with AIDS and HIV in the emergency department.
It really is very dependent on the region in which you practice and whether you do inpatient medicine, because really the only context I see it now is someone who gets admitted to the hospital with an opportunistic infection or gets admitted with a mysterious wasting illness that turns out to be not so mysterious after all.
After all,
Yeah,
right.
so.
Yeah.
In DC, it's interesting because there's a real dichotomy between who's getting chronic infection and who's not. Certainly in my experience, African Americans are the ones who are coming in very, very late. In large part because of the fact that even though they may know they're positive, they're not accessing treatment because of the stigma of taking the treatment and what that means in their community. So I saw several cases in working in DC of individuals who came in with T cells less than 50 and minor opportunistic infections.
Yeah, we still, in North Carolina, we still see, we probably have 2 or 3 cryptococcal meningitis. Sometimes there's people that are actually seen at an outside hospital. They're perceived at being lower risk. They might be a little bit older, like an older woman, for example. They're perceived to be at lower risk, so the diagnosis isn't necessarily considered. And the other thing you see is a lot of them have had an opportunity to be tested, and they're not tested.
Yes, there's actually quite a bit of literature on this.
Yeah.
And every infectious disease specialist has many, many anecdotes of people who bounced from clinician to clinician to clinician, getting unexplained symptoms and laboratory abnormalities worked up. The classic example is the bone marrow biopsy that's done before the HIV test because of leukopenia. I mean, that's just completely crazy these days.
1980s.
So David,
Sometimes
talk
it's
about,
not so subtle either.
Sure.
Sometimes it's it's a oral candida that may be seen by in the dental office or herpes zoster.
Sure.
Where there's been no HIV test, or
Right. Yeah.
new psoriasis, that an HIV provider would say, I think this person needs to be HIV tested, but doesn't always happen in a general practice or another subspecialist's care.
One last group of people who don't get diagnosed. There are some patients who do still refuse testing.
Sure.
And to be anecdotal again, there was a patient I saw from rural Vermont who had been seen by multiple clinicians, and several had recommended that he get HIV testing. He kept refusing. And then he insisted on getting a, quote, second opinion at the academic medical center in Boston that I work at. And the first thing I said to him was, you need an HIV test. So
Did he do it?
But he ultimately did it. But I mean, there are sometimes people who are so stigmatized by the diagnosis also are so afraid that they've just refused to get tested.
Using the opportunity when you encounter somebody to explain to them how good treatment really is,
Yes. Oh, yeah.
and how everybody has access to the best of
Right,
treatment.
definitely.
Those are often what drive people away.
Yeah.
They
Right,
think
they
they
think
can't
that,
access, the treatment isn't good, the treatment's toxic,
Right.
and even if it is good, they can't get it.
It's too expensive.
So-
And that's just not the case.